Welcome to the module of infections. Now, this is one of those topics where you don't have to understand quite a lot. It's mostly a lot of memorization and facts. But there is a story here, and I will share that story with you so that it becomes easy for you to understand and make the diagnosis to get your answer on the exam. Because that's the whole aim of MCQs on the exam. You need to make a diagnosis in order to answer the questions. So before beginning talking about osteomyelitis or septic arthritis or tuberculosis of the spine, the joint, I want to give you a broad idea about the infections that occur in the musculoskeletal system. So there are a few terms that you need to be familiar with. First is osteomyelitis. Second is septic arthritis. Now, what is osteomyelitis? Now, like every other module that I've discussed here, everything will be there in the slides. So don't worry about writing everything down. You can pause the video and make your beautiful notes. Just try to understand and listen to what I have to say, right? This is not something that you can pick up just by reading. So it is me who's basically trying to explain this to you in a very simple language. But the facts and fundamentals, they're already written on the PPT so that you can copy and make your wonderful, world-class, amazing notes. Okay, so what is osteomyelitis? So osteomyelitis is basically infection of the bone and the medullary cavity. So if there is infection in the bone involving the medullary cavity, that is considered as osteomyelitis. What is septic arthritis on the other hand? It is the infection of the joint, right? So the joint between the two bony ends. So infection of the joint is septic arthritis. Infection of the bone and the medullary cavity is osteomyelitis. Now please remember, osteomyelitis usually occurs in the metaphysis. In the metaphysis of the long bone, right? Somewhere around here, this is the location. And we will discuss why. There is science behind that. Now, you need to understand that this infection usually is bacterial. It can be pyogenic organisms or it can be tuberculosis. Pyogenic organisms usually produce a lot of local reaction that we'll talk about later in terms of periosteal reaction, in terms of swelling and abscess. So remember, pyogenic organisms cause a lot of severe local reaction in terms of periosteal reactions. Whereas tubercular organisms or tuberculosis of the bone is usually a muted reaction. The inflammatory reactions on the bone or the periosteal side are little muted compared to pyogenic organisms. So the findings that you might pick up on X-ray are usually much more evident when it comes to pyogenic organisms compared to tuberculosis. This I want you to understand as a fundamental. But there is an exception to this, and that is usually an MCQ. The exception here is tuberculosis of the small bones or the short bones, particularly the bones of the hand and feet. If there is tuberculosis of the bones of hand and feet, unfortunately, the local reaction would be very, very severe. So that is an exception to the rule that tuberculosis is usually muted. Tuberculosis of the short bones is severe in presentation in terms of local reaction. Okay, just keep this in mind. Everything will make sense to you. Now, looking at osteomyelitis first. That is the infection of the bone and the medullary cavity. What do you need to understand here? Osteomyelitis occurs usually in people who have relatively less immunity. So who are these people? These are usually very young children or elderly population. Okay? That's what you need to know. Now, how does this infection reach the bone? That is the question. Where does it come from? Now, it can come directly. Suppose you have a sharp object and you puncture the bone. The infection from that sharp object can get into the bone. That is a direct source. Or post-surgical. Suppose I'm operating and I'm not very careful. I have contaminated hands and I have operated the patient. The infection can reach the bone. So post-surgical or iatrogenic. Sometimes because of an open fracture. There was a trauma. The fracture is open. It is exposed to the environment. The organism will enter the bone and cause infection. Or from septic arthritis. As in from the joint, the infection has moved into the bone. Right? These are the sources. But remember, the most common source or the most important source is hematogenous. So there is a pre-existing infection in your body that has reached the bone through the bloodstream. That is the most common source of infection in terms of osteomyelitis. Please remember that. So what is the most common root of osteomyelitis, or what is the most common source of infection in osteomyelitis? The answer is hematogenous. Now the next question is, what is the most common organism that causes osteomyelitis of the bone? In fact, let me take a small moment here and tell you that most of the infections that occur in the musculoskeletal system, I am talking about orthopedics, the organism, the bug, the master bug or the king bug is usually Staphylococcus aureus. So if you are ever confused in marking which organism causes septic arthritis or osteomyelitis or tenosynovitis, you can safely mark Staphylococcus aureus. Now, obviously, there will be exceptions to this, and those will be MCQs, and we shall discuss them. But this is a broad, a blanket statement saying that Staphylococcus aureus is the most common organism infecting the musculoskeletal system. All right? Okay. So, most common cause is Staphylococcus aureus. Overall, the most common cause is Staphylococcus aureus. Now, sometimes the examiners will try to confuse you by triggering you with an unnecessary point in the question. They will say, what is the most common organism causing acute osteomyelitis or chronic osteomyelitis? Or what is the most common organism causing osteomyelitis in young children, in elderly, in males, in females, in Indians, in Americans, in Europeans? The answer will most of the times remain Staphylococcus aureus. So this is just there to help you understand that it is the most common organism overall. Most common organism causing acute osteomyelitis, chronic osteomyelitis, osteomyelitis in the developed countries, osteomyelitis in the developing countries, osteomyelitis in patients who have HIV, osteomyelitis in patients who get AIDS, osteomyelitis in patients who are immunocompromised, and osteomyelitis following open fracture. Also, the culprit organism is Staphylococcus aureus. An iatrogenic or post-surgical organism causing osteomyelitis is also Staphylococcus aureus. But like I said in the beginning, there are exceptions, and whenever there are exceptions, there are MCQs. So what are the special cases where the organism causing osteomyelitis is not Staphylococcus aureus? So here is the list, friends. This is what you have to memorize. I'm telling you, this is a topic where there is more memorization, less understanding. Right? Anyways, in sickle cell disease patients, the organism that causes osteomyelitis is mostly Salmonella. Please remember this, and I'll explain what is the trick here. Okay, it's Salmonella. Patients who are IV drug abusers, these IV drug abusers, if they get osteomyelitis, it's usually because of Pseudomonas, which comes from their IV drugs or the tips of their needles. If a patient gets osteomyelitis following animal bite, if an animal bites you and you get osteomyelitis in that bone, the organism usually is Pasteurella. And following human bite, suppose your best friend bites you, and you get osteomyelitis after his bite or her bite, you get osteomyelitis because of an organism known as Eikenella. Prolonged parenteral therapy patients in ICU taking total parenteral nutrition or taking parenteral treatment for very, very long durations or very, very long months and weeks, these patients, they are at increased risk of acquiring or getting osteomyelitis because of fungal organisms. Okay, so these are the things that you should remember because all of them are MCQs. Now coming back to a sickle cell disease patients and Salmonella. Listen carefully. If the question directly asks you, what is the most common organism causing osteomyelitis in a sickle cell disease patients, you can safely answer Salmonella because that is what is expected of you here. Sickle cell disease patient, mark Salmonella, move on, don't overthink. But now listen to me carefully. Salmonella osteomyelitis usually occurs in the diaphysis. But if you recall, I told you in the beginning that osteomyelitis mostly affects the metaphysis of the long bone. Right? Now, Salmonella affects the diaphysis. So if the examiner, now this has never happened before, but if they do this, then you should be ready. That's the job. If the examiner tells you there is a sickle cell disease patient and there is osteomyelitis in the metaphysis, what could be the most common organism? In that case, you can consider marking Staphylococcus aureus. Okay? Are you clear here? Otherwise, keep life simple. Sickle cell disease patients, mark Salmonella, move on. Okay? Is that clear? This is how you will approach these kind of MCQs. Now, coming to the site. The most common site. I've told you obviously it is metaphysis of the long bones, but let's dig deeper. Overall, the most commonly affected bone is femur more than tibia. And overall means usually in children, right? So infants and children. But if they specifically ask you what is the most common site of osteomyelitis in adults, then it is vertebrae. Okay, it's not as common as osteomyelitis in the femur that is seen in children, but you should be ready to answer these kind of MCQs. Now, let's go and investigate why metaphysis of the long bones is basically the most common location of osteomyelitis. And this is very interesting because you will learn a lot about the architecture of the metaphysis here. There are three important reasons why metaphysis of the long bone is the most common location to get osteomyelitis. The first reason is that it is the most vascular region of the bone, right? The majority of the blood reaches the metaphysis. So it's very vascular, highly nutritious, and a thriving real estate area for organisms to grow. Second is the blood vessels are arranged in a hairpin loop fashion. Now, what is this hairpin loop fashion? Let me show you. So this is your epiphysis, this is the growth plate, and this is the metaphysis. Okay? The blood vessels are arranged in this hairpin loop fashion. Now, what is this hairpin loop fashion? It is this shape. Okay, so how does it matter? Why does it matter? It matters because when the blood vessels are arranged in this hairpin loop fashion, the blood flowing through them has to turn around quite a lot. So the flow is sluggish, allowing for transmission or movement of substances from the blood into the metaphysis. So easy exit of the organism into the metaphysis. So because of sluggish blood flow. The third important reason why metaphysis is most commonly affected in osteomyelitis is because it is less protected. It has few monocytes and macrophages. The defense cells are very few in number. So the organisms are very happy to thrive in this flourishing area where there are very few policemen to kick them out. Now let's move on to the pathophysiology of osteomyelitis. First thing I want to tell you that acute osteomyelitis versus chronic osteomyelitis, these are all theoretical. Okay, these are all theoretical definitions of how the disease spectrum is. But essentially, please understand that it is a continuous process. Once an organism enters your bone, it will thrive there, it will grow there. So acute osteomyelitis will eventually become chronic osteomyelitis. And a lot of times this chronic osteomyelitis will flare up into acute osteomyelitis. So it's a spectrum of the disease. So I'll tell you the story of how this disease actually starts and progresses over time. And then I will tell you the clear definitions in terms of MCQs so that you can answer the MCQs on the exam. But in reality, acute osteomyelitis will eventually become chronic osteomyelitis, and a patient of chronic osteomyelitis usually comes to you with acute exacerbations of osteomyelitis. So it's a spectrum of the disease. So what is the spectrum here? What is the story here? I've told you that the bug, osteomyelitis ka bug jo hai, that is Staphylococcus aureus, comes to the bloodstream, that is hematogenous route, and gets into the metaphysis. Okay, so it will be the initial site of infection. There, because there are less monocytes and it is very vascular, the organism starts to thrive. It starts to grow. So what happens? There will be abscess that starts to form. There will be abscess, right? Because it's an organism. So there will be pus collection and there will be abscess that starts to form. Now, because of this organism growing and thriving there, the bone of that local area will not get the nutrition it needs. So the bone will start to die. As the bone starts to die, what happens? This dead bone becomes a warehouse of infection. The organisms are happily growing inside this dead bone, because dead bone is not a vascular bone. Dead bone does not have any defense cells or monocytes or macrophages. So organisms happily hide inside this dead bone and start to grow more. Now remember, what is this dead bone? This dead bone is known as sequestrum. Don't worry, everything is written. Just listen to me, listen to the story. You will be able to write down everything in the PPT. Okay, trust me. So this dead bone is called sequestrum. Now this sequestrum will allow or help the organism thrive. And so the growth of this organism or the pus will keep on increasing. Now, in the meantime, there is periosteum around the bones, right? There is periosteum around the bones. And I've told you in the beginning of orthopedics, there are two purposes of this periosteum. One is to provide nutrition to the bone. The other is to synthesize bone because it has osteoprogenitor, osteoblasts under it. When there is an infection in the bone, it is essentially an insult to the bone. So the periosteum will try to react to that insult to contain its spread. So what will it do? It will synthesize new bone in order to prevent the spread of this infection. So there will be this new bone that will form under the periosteum in order to prevent the spread of the infection. And this is what is known as periosteal reaction. Remember, we read this in bone tumors also. So it's a reaction of the periosteum to an insult. And the aim of this periosteal reaction is to basically contain the spread of the pathology. That is your body's defense mechanism. Right? So what happened again? Let's quickly review. Infection came, started to grow. It started to take a lot of nutrition. So the bone started to die. There was sequestrum. The periosteum started to react to this insult. So there was this periosteal reaction. So there is this new bone that forms around the infection. Now this new bone has a term. It's called involucrum. Don't worry. Everything is written. It's called involucrum. So we have understood what is sequestrum. We have understood what is this involucrum. Now this abscess, this pus keeps on growing and growing and growing and eventually perforates the involucrum and comes out through the bone enters the soft tissue plane. Okay? So it makes a hole in the involucrum. So what is it doing? It's making a hole in the involucrum and the pus is coming out. Now listen, this hole has a name. What is the name of this hole? It's called cloaca. Again, I'm telling you, don't write. Listen, everything is written. Okay? It comes out through this cloaca. So cloaca is a hole in the new bone, that is the involucrum. It comes out. It enters the soft tissue plane. And after it enters the soft tissue plane, what will it do? It will go towards the skin, perforate the skin and get out. Towards the skin and perforate the skin. So if there is a perforation in the skin through which the pus is leaking out, what do you call it in the medical language? You call it a sinus. So there will be skin here through which the pus will escape out, and that perforation in the skin is known as sinus. Again, friends, everything is written in the coming slide, so just bear with me. Okay, so this is the story of osteomyelitis. It starts with an organism getting into the metaphysis, goes all the way to the sinus where the pus escapes out through the skin. Okay, so this is the story. This is the story. Now let's try to categorize this to answer MCQs. So this is the diagram that I have drawn here. It's a beautiful drawing here. Nevertheless, what I have done is I have divided the spectrum of the disease into acute and chronic osteomyelitis for the sake of answering on the exam. So again, look at this. This is the epiphysis of the long bone. This is the metaphysis, and I'm trying to show you the hairpin loop arrangement. And I'm telling you that there is this organism that is entering here, and this black is the organism, and it has moved into the metaphysis, and it starts to form the abscess. So by 24 hours, around 24 hours after the infection, abscess would be formed. Okay. Now what happens later? This abscess keeps on growing, I told you, and the bone will not get the nutrition it needs, so the bone starts to die. That dead piece of bone is known as sequestrum. I'm showing you that this dead piece of bone is in the center of the abscess, that is the sequestrum. Now, the clarity is simple. Before the sequestrum, we call it acute osteomyelitis. After the sequestrum, we call it chronic osteomyelitis. Okay? Please bear with me. I'll explain everything again. Before sequestrum, osteomyelitis is acute osteomyelitis. Once sequestrum is formed, we call it chronic osteomyelitis. And then what am I showing you? I'm showing you this green is the periosteal reaction. That is the reaction of your periosteum in the bone to contain the spread of the abscess or the pathology. The black pus, that is the abscess, is coming out trying to perforate the involucrum here, and it has made a hole in the involucrum. And what is that hole in the involucrum known as? Cloaca. Very good. It comes into the soft tissue, perforates the skin and comes out. An opening in the skin is known as sinus. Right? Are you able to understand the spectrum of the disease, how it starts simply with an infection reaching the metaphysis and then perforates the skin and come out? Take care. Again, let me show you this diagram here. What is this? It's showing you a lower end of femur here. This is the metaphysis, diaphysis, epiphysis. This is the growth plate. You can see in the center you have your dead bone, that is sequestrum, surrounding by a cavity that was filled with abscess or pus, and then you see that there is this opening here, and you can see that the bone here is thick. This is the involucrum. There is an opening in the involucrum. You call it cloaca. It must have come out. The pus must have come out in the soft tissue, and then underneath the skin there must have been opening, and that is the sinus. Okay, right? Have you followed the story? I'll give you the specifics for your MCQs. Please follow the story because this is interesting. So less than 24 hours, we call it acute osteomyelitis before sequestrum. Less than 24 hours, systemic manifestations will be there. There will be pain and fever from the patient because abscess is very, very small. Pus is just started to collect. But after 24 hours, this pus collection is large, so abscess starts to form. Right? Okay? So far you've understood. Within 24 hours, there is just organism reaching the metaphysis. Abscess is not there, just pus collection is there. Patient will complain of pain and there will be fever. After 24 hours, this collection of pus will be large enough to call itself an abscess. Periosteal reaction is the reaction of the periosteum to contain the spread of the pathology and usually starts around 7 to 10 days. So this is an important MCQ. When does the periosteal reaction start? It around 7 to 10 days. That is by second week of infection. Sequestrum starts to form in the contents of the abscess because it is not getting the nutrition that it's supposed to be getting because abscess is taking the nutrition away. Abscess perforates the involucrum and that perforation is known as cloaca. Pus drains through the involucrum and discharges out of the skin through the sinus. Like I promised, everything is written here. You can write down in your notes, but I'm sure you have understood the story. Now, after understanding the story, what are the key points you should remember? The first key point is abscess forms after 24 hours of infection. It's a very important critical phase. If a patient comes to you before 24 hours, you assume that there is no abscess there. So simple treatment of antibiotics would suffice. After 24 hours, abscess is there, and whenever there is an abscess in the body, it always has to be drained. Okay, so intervention surgical ho jata hai. Okay, did you understand this? So this is the first key point. Second key point is periosteal reactions. When does the periosteal reaction start? Around 7 to 10 days, that is 2 weeks after the infection. This is important because now they will ask you MCQs around the radiology of periosteal reaction, and we will show you how. Sequestrum by definition is dead bone separated from the normal bone hidden inside the abscess. What is involucrum? It is the new bone that is formed under the periosteum as a reaction to the insult. It's a new bone that contains the spread of the infection, whose aim is to basically contain the spread of the infection. And what is cloaca? It is the opening in the involucrum through which the pus debris come out. And what is sinus, friends? It is the perforation or opening in the skin through which the pus drains out of the infected bone through the skin. Okay? As promised, everything is written. You don't have to worry. Now that you've understood the story, let me ask you what will be the clinical features of the patient who present to you with osteomyelitis. Clinical features kya hoga? Obviously, because there is infection, the patient will have fever. It will be a young child who will have fever. And because the infection is in the bone, whenever the patient will move the limb, there will be pain. So patient will be hesitant to move the limb. So let's look at this. Patient will have high-grade fever, and it will usually be a young child with swelling and pain. These are typical inflammatory findings that you will find. And because of this pain, the patient will be hesitant to move the limb. We call this pseudo-paralysis. Now please understand, this is not paralysis. This is pseudo-paralysis, and patient is not moving or is in paralysis because of pain. That's why it's called pseudo-paralysis. There are many conditions that cause pseudo-paralysis where the baby doesn't want to move the limb because it will cause him pain. Septic arthritis is one. Osteomyelitis is another. Vitamin C deficiency, scurvy is another. There is subperiosteal hemorrhages which cause pain. So there are many causes. One of them is osteomyelitis. So that is the clinical presentation of osteomyelitis. Now what about acute and chronic? How will you differentiate them in terms of presentation, clinical presentation? So we have hallmarks to help us differentiate. Clinical hallmarks and pathological hallmarks. Clinical hallmarks are something that you can see clinically. Pathological hallmarks are something a pathologist will see and tell you. So what are these? The clinical hallmarks are very simple. If the patient has a sinus, it is chronic osteomyelitis because sinus will not be there if there is no sequestrum. And if there is no sequestrum, it is not chronic osteomyelitis. So sinus is the clinical hallmark for chronic osteomyelitis. Now what about acute osteomyelitis? What will be his clinical hallmark? No such thing, right? There will be fever, pain, which are non-specific. So there is no hallmark here, no clinical hallmark. What about pathological hallmark? Chronic osteomyelitis, by definition, needs a sequestrum. So sequestrum for chronic osteomyelitis. And pathological hallmark for acute osteomyelitis? Actually not much, but you can say abscess. You can say abscess. So if there is a sequestrum, chronic osteomyelitis. If there is a sinus, chronic osteomyelitis. If there are none, usually acute osteomyelitis. Are you getting the picture here? Right? So this helps us basically differentiate clinically as well as pathologically, and there will be direct MCQs asking you what is the clinical and pathological hallmark of chronic osteomyelitis. Okay. Now let's talk about the management. How will we manage osteomyelitis patient? The first thing you should do is you should collect the blood sample. This is very important because I told you the infection mostly comes from the blood, hematogenous spread, right? So you have to collect the blood sample to identify the bug. But unfortunately, the problem is only 50% of the cases actually show the bug Staphylococcus aureus. But nevertheless, you should still consider taking the blood sample before starting anything. Because what happens usually is before collecting a blood sample, if you start the patient on antibiotics, the antibiotics may cause problem in the sensitivity or the culture of the organism, thereby making you use antibiotics irrationally. So that is a major concern in terms of antibiotic resistance. So the best thing to do is to collect the blood sample beforehand to identify the exact bug and the sensitivity of the antibiotics for that bug, and then give the desired antibiotics to attack that bug instead of giving multiple antibiotics and seeing which works. Don't do that. Okay, so the first thing to do is collect the blood sample, send the blood sample for culture and sensitivity to identify the organism, and also look for the blood picture. You might see because of infection by pathogenic organisms, WBCs and neutrophils would be high. The ESR and the CRP would also be high. But again, all of these things are non-specific, and like I said, only 50% of the cases show positive culture for Staphylococcus aureus. Then what should you look for? Procalcitonin these days. Serum procalcitonin is a very sensitive and specific marker helping us make a diagnosis of osteomyelitis or septic arthritis. And in ICU, a lot of sepsis cases show elevated serum procalcitonin, and this can basically help you make a diagnosis. Now, what do you do? Once you've collected the blood sample, what do? You start the patient on broad spectrum antibiotics as an empirical management. Once the culture comes, you can change to the specific antibiotic that works for that bug. But otherwise, start the patient on broad spectrum antibiotics. Now, obviously, the patient will be in fever, the patient will be in pain, so you have to do the symptomatic treatment. For pain, give analgesics. For fever, give antibiotics. What about the limb? The patient is not moving the limb because it will cause pain, so support the limb. Use splint. Provide rest. If there is local rise of temperature, if there is swelling, apply ice pack and give limb elevation. These are general things that I think everyone who's in orthopedics will do. What else can you do? Do you have any help from radiology that can help you make the diagnosis? Yes, you have, and hence a lot of MCQs. They will ask you which radiological investigation will pick up the changes earliest, or what is the earliest changes that you can pick up on X-ray, or which is the earliest bony change that you can pick up on X-ray. So these are all confusing MCQs, and let me break them down simply for you. You see, the earliest radiological modality that can pick up any sign of osteomyelitis, it would be MRI. And what will it pick up? It will pick up marrow edema within 24 hours. Within 24 hours. So within 24 hours, marrow edema will be visible on MRI. So earliest radiological investigation would be MRI to pick up marrow edema. After that, bone scan can also help. You can see positive for technetium 99, gallium 67, or indium 111, WBC labeled accumulation there in terms of infection. Not very important. X-ray is important now. Now there are two important MCQs here. When does the X-ray pick up changes earliest? Okay, X-ray usually requires 24 hours to be gone. After that, it will pick up. So X-ray changes are usually seen after 24 hours. This is important. It shows after 24 hours. So when before 48 hours, within 48 hours. So within 24 hours or less than 1 day, MRI, or less than 2 days, you can say X-ray. Now this is an interesting question. What is the earliest X-ray change that you will see in osteomyelitis? The earliest X-ray change is soft tissue lucency or shadow around the bone. Now, is it a bony finding or a soft tissue finding? It is a soft tissue finding. Very important. It is a soft tissue lucency or a soft tissue shadow around the bone that is picked up on X-ray. So this is the earliest X-ray change. First MCQ. Well, second MCQ is, what is the earliest bony change on X-ray? So what is the earliest bony change on X-ray? It is the periosteal reaction. And when does it become visible? Tell me, when is periosteal reaction seen? Around 7 to 10 days. That is around 2 weeks. So be very careful when you answer this MCQ. Earliest X-ray change, soft tissue lucency around the bone. After 24 hours or within 2 days. Right? First. Earliest bony change on X-ray, it is the periosteal reaction by 2 weeks or 7 to 10 days. Okay. Earliest radiological investigation that will pick up the diagnosis for osteomyelitis, MRI, within 24 hours. And what will it show? It will show marrow edema. These three MCQs you should know in terms of radiology of osteomyelitis. But nevertheless, all these investigations, they are not very specific. So the gold standard investigation that will help you make the diagnosis without any kind of doubt is biopsy. Go to the tissue, take out the tissue and look at the tissue. What will you find? You will find the bug or you'll find the pathology there. So biopsy is the gold standard investigation. Now let's talk treatment. How do you treat this acute osteomyelitis? Now, if the patient presents within 24 hours, that is less than 24 hours, the abscess has not yet formed. So antibiotics usually suffice. So antibiotics plus minus if you require to drain that abscess. But usually abscess is not there. Antibiotics usually work. But unfortunately, people don't come to you within 24 hours. They come to you after that. and by that time abscess would already be formed. So in that case, if the patient comes to you after 24 hours, antibiotics, yes, you have to give, but since there is an abscess, you always have to drain the abscess. Now, how do you drain this abscess in the bone? So this is the bone, there is an abscess here. You just take drill and you surgically make drill holes. You make drill holes to allow that pus to drain out, and you wash it away. That's it. That will take care of it, because it will be just a small collection and it will just be cleared. It will be cleared. If it doesn't clear over time, it will become chronic osteomyelitis, and that's what usually happens, because it doesn't clear as easily as we think it does. Anyways, so what is the treatment of this antibiotic duration? How long do you give this antibiotic for a patient of acute osteomyelitis? Roughly around 6 weeks. 2 weeks of IV, that is parenteral antibiotic, is given, followed by 4 weeks of oral antibiotics must be given. Right? Why such a long duration? Because the infection is in the bone. The penetration is very less of the drug. That's why you need to give it for a very long duration. So the drug penetrates the infection and controls it. Okay. You can also use CRP to assess the response of the antibiotics. Now that is the treatment. What is the complication? The complications of acute osteomyelitis. Before we begin further, let me just tell you that provisionally osteomyelitis has been divided into acute and chronic osteomyelitis. Acute osteomyelitis is usually the infection of the bone in less than 2 weeks, and more than 4 weeks is considered chronic osteomyelitis. Now, this is not a very good classification, because it's just dependent on the duration. And it's not right, because we know that for chronic osteomyelitis, we need sequestrum. Right? So, but you need to know it, because it's out there. People call osteomyelitis of less than 2 weeks duration acute and more than 4 weeks duration chronic. And between 2 to 4 weeks, you call it subacute osteomyelitis. So that is a classification that is out there, but not a very good one. Anyways, moving further, what are the complications of osteomyelitis? The most common complication of acute osteomyelitis is chronic osteomyelitis. I've told you that. Because when you make those drill holes, hoping that the pus would drain, usually some amount of it is left inside, and it will flare up later or still be there for a very long time. And that becomes an abscess, which will eventually become a sequestrum. That will lead to chronic osteomyelitis. Most common complication of acute osteomyelitis is chronic osteomyelitis. What are the other complications? Septic arthritis. So this is the bone. This is another bone. So there was infection here, which moved into the joint, leading into septic arthritis. Okay, and I'll tell you how and why. Septicemia, we all know septicemia can be a complication of any kind of infection. Growth disturbance, because there is infection here and there is a growth plate here, it can cause its damage, so the growth will be disturbed. These are the complications. Now the interesting complication is septic arthritis, because we all should know that just above the metaphysis, there is this growth plate, right? I told you. This growth plate is basically preventive, protects the joint. Preventive of spread of infection from the metaphysis into the joint. It prevents the infection, right? So before the growth plate formation, that is less than 2 years, where the growth plate is not there, the infection will likely move. So in very young children, infants, less than 2 years, because the growth plate is not there, the infection from osteomyelitis will go into the joint, causing septic arthritis. Or after growth plate fusion. In adults, as in mature adults, the growth plate would be fused and it will be gone. So the infection from the metaphysis would reach into the septic joint, causing septic arthritis. So in children less than 2 years or after skeletal maturity, this complication is seen. But between 2 to around 14 or 16 years, where there is growth plate still there, the infection is less likely to move from metaphysis into the joint. That is what you need to know. Growth plate or physis prevents the spread of infection. Okay. Now let's talk about chronic osteomyelitis, because that is the eventual sequelae of acute osteomyelitis, right? Now, what is chronic osteomyelitis? I told you, usually more than 4 weeks following the infection. That is just an arbitrary definition, but you need to know for MCQs. The clinical hallmark is presence of sinus, and the pathological hallmark is presence of sequestrum. Now, what is this sequestrum? It is that dead piece of bone inside the abscess, right? It is this dead, dense, devascularized bone that is surrounded by the granulation tissue and involucrum. And microscopically, it's a totally destroyed or disstructured bone. There is microscopic destruction of the Haversian system. It's not a normal bone, it's a dead bone. So remember, dead bones are dense bones. Dead bones are dense bones. So it's a dead, dense, devascularized bone sitting inside the abscess in the granulation tissue, surrounded by involucrum all around. And microscopically, the Haversian system is destroyed. That is what is your sequestrum. Okay? That is what chronic osteomyelitis. And if that patient has chronic osteomyelitis, eventually he will come to you with a discharging sinus clinically, right? And that is how you make the diagnosis. So this is an image of one of my patients, a young child, who came to me with this discharging sinus around the proximal tibia, somewhere in the middle of the tibia over here. So what did I do? I got an X-ray. And what did I see on X-ray? I saw the involucrum, I saw the sequestrum, I saw the cloaca, I saw everything. And let me show you how. So this new thick bone that is being formed here, that is your involucrum. Okay, and this dense white long thing that you can see here, dense white long thing. I will erase these markings so that you can appreciate the X-ray later. This is sequestrum. Okay, so let me show you without these markings. Can you see this relatively dense piece of structure here? That is what is your sequestrum. So obviously, what did I do? The treatment has to be sequestrectomy, and I'll show you what I did later. So again, let me show you the X-ray here. Patients will have clinically sinuses. On X-ray, there will be this dense new bone that is formed on the surface of the periphery that is known as involucrum. And there will be this white dense bone in the center. That is your sequestrum. And there will be an opening in the involucrum that is known as cloaca. And I've explained all of these things to you. So this will be the findings on X-ray. You will see a dense white bone in the center of the medullary cavity, that is sequestrum. Surface, there will be thickened bone, that is involucrum. There will be an opening in the involucrum, that is your cloaca. Okay. Now, there are many types of sequestrums. Okay, there are many types of sequestrum based on their shape and location. And since there are many types, there will be MCQs. So what are the types of sequestrum? The normal sequestrum that you see in Staphylococcus aureus, it is tubular sequestrum. Okay, it is tubular. So look at this image here. It looks like a tube. Okay, it's tubular, long tubular sequestrum. Okay, here again it looks like a tube. Okay, tubular sequestrum seen in acute pyogenic osteomyelitis. Now there are others. Coralliform sequestrum is seen in Perthes disease, because Perthes disease is nothing but avascular necrosis, dead bone. Feathery, flake or coarse sandy is seen in tuberculosis. Fine sandy is seen in viral osteomyelitis. Buttonhole seen in post-radiation necrosis. Ivory sequestrum is seen in syphilis. All of these are important. All of these are your MCQs one-liners. But recently in their INISET exam, ring sequestrum was asked as a question. Ring sequestrum is a sequestrum, that is the dead bone, seen around the pins that you put in the bone. So pin tract sites. Ring sequestrum seen around the pin tract sites. So let me explain. See, suppose a patient comes to you with open fracture, and if you remember your basics, open fractures are initially managed with your external fixator. So you put these pins into the bone. You put these pins, the Schanz pins or K-wires, you put these pins into the bone to stabilize the fracture. And you stabilize these pins with the rod outside the body. So this rod stabilizes the pins, and eventually the pins will stabilize the bone. We've talked about this in your basics. You can go and review that video. You know what external fixator is. Anyways, so these pins, when you're inserting at the bone, that part where it is being inserted, this part of the bone can't undergo necrosis. And since it's a dead bone, it's a sequestrum, right? So this is known as ring sequestrum because they are in the shape of a ring. I'm clearly showing you an image here where the pins are getting infected and you can clearly see pus coming out through the skin. So this is your ringed sequestrum seen at pin tract sites. Okay, that is all about sequestrum. But let's come back to the chronic osteomyelitis, the management of chronic osteomyelitis. How will you manage chronic osteomyelitis? There's a patient with sequestrum, there's a patient with sinus, there's a patient with cloaca, there is a patient with involucrum. How will you manage it? First things first, like any infection, collect the blood sample. Start the patient on broad spectrum antibiotics. This is the first thing you will do. Then you will obviously do symptomatic management, painkillers for analgesics for pain, antipyretics if the patient has fever. But usually chronic osteomyelitis patients do not have high-grade fever as in acute osteomyelitis because their body has adapted to that kind of infection. Now you need to do one more very important thing. You need to take out the tissue to make the perfect diagnosis. Like I said, any kind of infection, the best investigation is take out the tissue and look for the bug. Now, since there is a sinus, you can use sinogram to understand the anatomy of that sinus because you will eventually have to remove everything that is there in the bone that is causing infection, which starts from the sinus tract, the cloaca, the sequestrum. All of these things have to be removed so that the infection is completely removed from the bone. So in order to understand the pathway of the sinus, you perform sinogram where you inject the dye radio opaque dye, and then you take x-rays. So that the dye will be visible on the x-ray, so you can understand the tract. Anyways, please remember that the treatment of chronic osteomyelitis is always surgical. Why? Because there is a dead piece of bone inside. You cannot conservatively manage it just with antibiotics. You have to manage it surgically. You have to go in, remove the sinus, you have to remove the sequestrum, you have to remove the sinus tract, and you have to open up the bone so that hidden pieces of the infection get out and so that recurrence is minimized. So what will you do? Under antibiotic cover, go for sinus tract excision, sequesterectomy, debridement, saucerization of the bone, and curettage. Remove every piece of dead and dirty bone till fresh bone is visible. And how will you identify fresh bone? When there is fresh bleeding after curettage. And you have a sign for it. It's called paprika sign. I'll explain. So remember this kid who came to me with infection in the tibia with a discharging sinus. I got an x-ray. I identified that there was an involucrum, there was a sequestrum, there was a cloaca. So what did I do? I posted him for surgery. And these are the findings that we found. So this is me basically operating on this tibia. And what have I removed here? What have I removed? This chunk of bone, this long chunk of bone that is visible over here, that is the dead piece of bone inside the tubular bone, right? Inside the diaphysis, the long piece of bone that I've removed. This is your sequestrum. This is your sequestrum. Then this dead piece of bone. See, I've kept it here on the cloth for you to easily visualize. This is known as sequesterectomy. I've removed the sequesterectomy. And then what did I do? I curated the cavity. I opened up the cavity and I started curating. Till what point? Till you start to get fresh bleed. Till you start to get fresh bleed means all dirty and necrotic tissue is removed and you're getting fresh bleed. So on the background of a white bone, when you get these red bleeding points, you call it paprika sign. Paprika is these red chili flakes that you put on your pizza, right? On the white cheese of the pizza, if you put these red chili flakes, it will give you that appearance. So paprika sign. This is known as paprika sign. Till you get fresh bleed, you have to remove and debride the tissue. And also make sure that the cavity is opened up. That is known as saucerization. So if there was an infection here, make sure you open up the cavity like this so that infection, if residual infection is there, it should escape out. Never go for cavity that is like this, because if there is any residual infection here, it might not escape out, rather it will start to grow inside. So make sure you make a wide mouthed cavity like this, like a saucer, so that the organism escapes out without collecting. That is known as saucerization. So you've understood sequestrectomy, you've understood saucerization, you've understood curettage and debridement till paprika sign. Now, once you have done the saucerization, how will you close this dead space that you have created in the bone? You can fill it up with new bone graft or you can use bone cement. So let me show you an x-ray here. We have done saucerization and now we are closing that saucerization with bone cement. Okay, so this cavity has been closed with bone cement, or you can use a bone graft. Okay, now what about this skin covering? This skin covering sometimes require a skin graft or a muscle graft. So a skin flap can be used or a muscle flap can be used. And nowadays we have VAC, that is vacuum assisted covering, that is negative pressure wound therapy, where you apply a lot of negative pressure over the wound, which will remove all the exudate that collects there at the wound, help in promoting healing by forming a lot of granulation tissue. You will read more about this in general surgery. The pressures that are used for negative pressure wound therapy is -75 to -120 millimeters of mercury. And also remember, there is an MCQ. Negative pressure wound therapy is contraindicated if the patient has a scar or a tumor at the site where you plan to use it. Okay, so that is how you treat chronic osteomyelitis. The treatment is always and always surgical. And finally, what will be the complications of chronic osteomyelitis, right? So the most important complication is pathological fracture. You see, because of this destruction of the bone by the abscess and sequestrum formation, the bone will become weak, and if you apply force, it might break. Right? Bone is weakened, application of force will lead to its breaking. Pathological fracture is the most common complication of chronic osteomyelitis. Other complications are acute exacerbation, neoplastic changes of the sinus tract. The sinus tract may become a squamous cell carcinoma. Please remember that. And because it's a long-standing chronic infection that takes years and years to treat itself, and because it's a long-standing condition that lasts for months to years, amyloidosis will sometimes show itself. Now, those are the classical acute and chronic osteomyelitis we discussed. Now, there are variants of this. and we have Brody's abscess and Gary's sclerosing osteomyelitis. Let's understand what it is. There are two important variants. One is Brody's, another is Gary's. Like I said, everything is written. Just listen to me. Brody's and Gary's. The important takeaway here is that these conditions, the variants of osteomyelitis, have no sinus. They will not have any sinus and they will not have any sequestrum. And another important fact is that these are the people who have very good immunity. The people who get these variants of osteomyelitis, they have very good immunity, and the organism that gets in to cause this variation of osteomyelitis is actually weak. So this weak organism enters a strong host where it cannot grow. Your body will contain it because body is strong, the organism is weak, the body will kill it, break it, and there will be a tombstone of this organism inside the bone. These are the variations that we are talking about. Otherwise, what was the criteria for osteomyelitis? The immunity would be low and the organism would be strong. That is where you get osteomyelitis. Here, it is quite the opposite. The immunity is strong. So remember, these variations of osteomyelitis that we are going to talk about now in terms of Brody's and Gary's will not occur in immunocompromised individuals. It cannot. It cannot. For Gary's and Brody's to manifest, you need good immunity. You need good immunity. Okay. So there are two types. One is Brody's abscess. The other is Gary's sclerosing osteomyelitis. Both of these are slightly different from acute and chronic osteomyelitis in terms of they will have no sinus and there will be no sequestrum. Brody's abscess is subacute type of osteomyelitis, whereas Gary's is chronic osteomyelitis. Again, this is based on the duration, right? Brody's is 2 to 4 weeks and Gary's is more than 4 weeks. Not very important, but sometimes they ask you as an MCQ. Now, what is the problem here? The story here is that the organism is weak. It enters the bone. The immunity is good. So your body contains it, kills it, does not allow it to flourish and grow, and forms a thick layer of bone around it. And that is what happens. So what happens here, say look at this diagram. This is the tibia and this is the femur. The organism has reached the metaphysis, started to grow. Because it is weak, the body has killed it and there is a relatively thick sclerotic rim around the bone. This is your classical Brody's abscess. And clinically also, the patient will have not a lot of symptoms. There will be mild pain, mild to moderate pain, mild fever, that's it. Slight elevation of ESR and CRP, nothing else. The body has contained it. But the only problem is that there is still some pus there. So the treatment of Brody's abscess is antibiotics with or without some debridement. What will you see on X-ray? No periosteal reaction, but there is a thick sclerotic rim. Okay, central lucency surrounded by thick sclerotic rim. On the other hand, what is Gary's sclerosing osteomyelitis? This is a chronic variant of osteomyelitis where the periosteum has reacted to the organism and it has killed it. The only disadvantage is that the periosteum has reacted a little more aggressively than it should have. Organism is dead, no doubt, but there is excessive bone formation also. That is what happens. You see this thick, dense bone that is being formed here. That is Gary's sclerosing osteomyelitis, right? So the most common site here is mandible. There is no pus, but there is excessive bone swelling because of excessive periosteal reaction. That's why it is sclerosing. And since there is no pus there, you don't even have to go for debridement. You just go for antibiotic treatment. Okay, so Brody's abscess, antibiotic treatment, and also try to remove the pus by debridement. Gary's, you just have to go for antibiotic. Gary's, there is no pus, it's just a sclerosing osteomyelitis where there is excessive periosteal reaction leading to excessive bone formation. This is an MRI finding of Brody's abscess. It has been asked as an MCQ. This radiological appearance on MRI where there is a central lucency surrounded by a dense sclerotic rim has been described as penumbra sign. Penumbra sign. Penumbra sign, and it can also be seen in chronic osteomyelitis, so not very specific, but you need to remember it for your exam. This is known as a penumbra sign. And a few more x-rays of Brody's abscess that can be asked on your exam. Again, look at this. In the metaphysis, there is central lucency surrounded by dense sclerotic rim. Now don't get confused by any bone tumor here, because this patient of Brody's abscess will present you with mild to moderate pain, a slightly elevated ESR, CRP, a low-grade fever, and inflammatory and infective kind of presentation. So that is how you make the diagnosis. Again, look at the distal radius here. You will see a Brody's abscess. Again, look at the distal tibia here. These are all the radiological findings of Brody's abscess. Now, in the similar vein, let's move on to septic arthritis. Here, the organism, through hematogenous route, has reached the joint and has started to grow inside the joint, right? Septic arthritis. Remember, it's a surgical emergency, and I will discuss why it is an emergency. We need to get the pus out of the joint as soon as possible. Otherwise, it will cause destruction of the joint. Okay. This is much more dangerous than acute osteomyelitis, and we'll discuss why later. Okay, this is the organism, bacterial or arthritis. What will be the organism? Most common organism would be Staphylococcus aureus. Like I said, staph. Every infection in musculoskeletal system that is bacterial, think staph as the organism. But obviously, there will be exceptions to this rule. For example, IV drug abusers, septic arthritis occurs because of Pseudomonas. Another interesting MCQ, sexually active individuals, if they get septic arthritis, it is usually by Gonococcus. Again, what is the usual age group of septic arthritis? Again, people with less immunity relatively, that is young children or elderly population. Children are the ones that I have mostly seen in my practice. Now, what is the joint that is most commonly affected? The most commonly affected joint is the knee joint, but remember, infants mostly have septic arthritis of the hip, right? Newborn babies, say 7 day, 10 day, 15 days, 3 months, 4-month-old baby, they come to me with septic arthritis of the hip, and that has a different name altogether. That's called Tom Smith's arthritis. We'll talk about that in a bit, but that is the most common location in infants. So remember, knee overall is the most common location. In children also, knee is the most common location of septic arthritis, but in infants it is usually hip, and I've told you that the root is hematogenous. Now you tell me, what will be the clinical features of a patient with septic arthritis? Obviously, there will be systemic findings and local findings. Systemic findings means it will usually be young child with high grade fever, right? High grade fever. There will be inflammatory signs locally, as in swelling, pain, and redness. As in swelling, pain, and redness. Now, this pain is very important. The patient, number one, will not move the limb because of the pain in the joint. Number two, you will keep the joint in a particular position, and there is a reason behind this. So please understand that when we say septic arthritis, although the articular surface, that is the cartilage that is getting destroyed, is not the one that is causing the pain. It is the capsule that is getting stretched because of effusion into the joint that is causing the pain. Please understand this very important point. Capsule is the pain sensitive structure of the joint. It's not the articular cartilage. Articular cartilage, in fact, is aneural, alymphatic, avascular, is painless or has no sense to pain. So even if it gets destroyed, you will not feel the pain because of articular cartilage destruction. This is the distension of the capsule. See, this is your distal femur, this is your proximal tibia, and this is the capsule around the joint. In septic arthritis, there is infection inside the joint, and because of this, there will be effusion, lots of pus and lots of collection inside the joint. So there will be a lot of fluid inside the joint, and when there is lots of fluid inside the joint, it will be stretching the capsule, and this stretch of the capsule is what causes the pain. The capsule will be tense, it will be stretched, and this causes pain. So what will the patient do? The patient will try to decrease the pain. And how will he decrease the pain? He will try to decrease the stretch of the capsule. And how will he decrease the stretch of the capsule? He will decrease the stretch of the capsule by positioning the joint in such a way that the volume inside the joint increases. Are you following me? What happens when the volume increases? When the volume increases, the pressure will come down. And when the pressure comes down, the stretch of the capsule comes down. And when the stretch of the capsule comes down, the pain goes down. So what is this position for the joint? That is known as the position of ease. Okay, so that will be another important clinical feature. Now, like I said, there will be effusion. So there will be distension of the joint. And when there is distension of the joint, there is one more important clinical feature that can be seen in the knee joint. What is that? Patellar tap sign. See, normally, say on the lateral view, this is your distal femur, this is your proximal tibia, there is your patella here. If there is effusion, okay, if there is effusion here, what will it do? It will lift the patella up. So patella will be at a higher level. Patella will be at a higher level because there is effusion in pus here. So you can press on the patella and it will go down. So that's known as patellar tap. So there will be positive patellar tap sign. समझ आया? The positive patellar tap sign that will be seen in knee septic arthritis. And the patient will keep the position in the position of knees. Position of ease. The patient will keep the position of the joint in the position of ease. So what is this position of ease? Where the volume is more, hence the stretch of the capsule is less, hence the pain is less. You have to remember, for hip, the position of ease is flexion, abduction, external rotation. And for knee collections or knee effusions or knee synovitis, the position of ease is 5 to 30 degrees of flexion. 5 to 30 degrees of flexion. Somewhere around 5 to 30 degrees of flexion. Okay, little bit of flexion, 5 to 30 degrees of flexion. That is the position of ease for knee. Let me show you. This is the position of ease for knee, and for hip, this is flexion at the hip, abduction at the hip, and external rotation. So for hip, position is flexion, abduction, external rotation, and for knee is 5 to 30 degrees of flexion. In this position, the joint will have maximum volume, maximum capacity. So when it has maximum volume and maximum capacity, the effusion and the contents will not push the capsule. And when the capsule is not pushed, it's not stretched, hence the pain comes down. So whenever a patient has effusion in the joint, he will keep the limb in this position. He'll keep the knee in this position. He'll keep the hip in this position. So this becomes a very easy clinical marker for you to make the diagnosis that the patient has some effusion in the joint, and that is why he's keeping the joint in the position of ease. Otherwise, why would he keep it in the position of ease? Are you following me? So that is what will help you make the diagnosis clinically of septic arthritis for knee as well as for hip. But the most common location is knee. Now let's talk about the management of septic arthritis. Septic arthritis is an emergency. All right. The diagnosis is usually clinical. You don't have to make a diagnosis and then proceed to treat septic arthritis, because by that time it will usually be too late. So, but if you want to stick to protocol, the first thing you should do is collect blood sample and send for CBP, ESR, CRP, and for culture. But again, you don't have to wait and do this, but collect the blood sample nevertheless. And then what do? Your aim here is to basically go in and remove the contents of the joint, because these are the things that are destroying the joint. And we'll go in great details later once we have covered the algorithm of management. Okay, so please remember, it's an emergency. All of these are just theoretical. It's a clinical diagnosis. You have to go in and get the contents of the joint out so that it stops the destruction of the joint, because pus is dangerous for the joint. Let's see. So first step is collect the blood sample, do CVP, ESR, CRP, and you will find elevated WBCs. Send for culture. X-ray usually does not show a lot of changes. Early stages of the disease, there are usually no changes. MRI might show synovial thickening. Again, not very significant, not important. Ultrasound, yes, you can go for ultrasound guided arthrocentesis. What is this arthrocentesis? Arthrocentesis is basically going inside with a needle and removing the contents of the joint. Right? So removing the contents of the joint is arthrocentesis. You can use ultrasound to guide you so that you are in the proper joint to remove the content. This is helpful. This is both diagnostic and therapeutic, because diagnostic, you can remove the pus and see what is the organism, and to make a diagnosis of septic arthritis. And also you're removing the pus out of the joint so that the destruction of the joint is minimized. But at the end of the day, remember, the treatment of septic arthritis is to get the contents of the joint out because they are septic. All right. The best way to do is by an arthrotomy. Arthrotomy means arthro means joint, otomy means opening the joint. Open the joint, wash it, and remove the joint under antibiotic cover. Wash it and remove the contents of the joint, not the joint. Wash it and remove the contents of the joint, that is pus. And I will tell you why you need to do it ASAP, because if you don't do it in time, you will end up destroying the joint. So this is what happens. The pus that is collected there inside the joint, it's basically the collection of the organism, and it contains a lot of enzymes. These are enzymes that cause destruction of the lining cartilage of the joint. And because of this destruction, what happens? The articular cartilage is eroded, and then there will be two raw ends of the bone sitting on each other. And eventually what will happen, these bones will start to heal into each other, becoming fused like a bone, because there is no articular cartilage between it, because it's destroyed by the enzymes of the pus or the organism. So you see, the organism releases the proteolytic enzymes like collagenases, metalloproteinases, elastases, which destroy the articular cartilage, leading to fusion of the two raw bony ends. This fusion by the disease process is what is known as ankylosis. What is ankylosis? Ankylosis is fusion. Ankylosing spondylitis, remember, ankylosis is basically fusion by disease process. Ankylosis is fusion by disease process. You see, this is a normal joint, and this is septic arthritis. The pus is destroying the articular cartilage, and you are left with two raw ends of the bone, which will eventually fuse with each other. And if this fusion is in the form of a bone, you call it bony ankylosis. So bony ankylosis is usually the end sequelae of a neglected septic arthritis. And that is why it's an emergency. If you do not intervene in time, the articular cartilage will start to destroy. And once it is destroyed, you have two raw ends of the bone that will fuse into each other, ankylosis, and it is usually in the shape of a bone or in the form of a bone, it's called a bony ankylosis. So patient will lose the joint. And that is why septic arthritis is an emergency and you have to go in and treat it as soon as possible, because articular cartilage once starts destroying will not heal, and usually the pain will not be there because of destruction of the cartilage. Okay? So you have to make a diagnosis quickly and go in, remove it. Now listen, when I said ankylosis, you have to first understand it's the fusion of the joint because of a disease. Now this is in the form of a bone, it's called bony ankylosis. So pyogenic organisms causing septic arthritis usually end up in bony ankylosis. Please remember that. Is there any other form of ankylosis? Yes, fibrous ankylosis. What happens in fibrous ankylosis? The bones will fuse with each other, but with a fibrous tissue, not with a bone. So there will be some amount of movement. So let's try to differentiate between bony and fibrous ankylosis, and let's see in which conditions you get bony and in which conditions you get fibrous. So fibrous ankylosis, what happens? There is fusion between the raw ends of the bone with fibrous tissue. Bony ankylosis, what happens? There is fusion between the raw ends of the bone with bone. Bony ankylosis. So bony ankylosis usually occurs because of pyogenic septic arthritis. Very, very important. And fibrous ankylosis usually occurs because of tubercular arthritis. Another important MCQ. Like I said, TB causes less reaction. When there is less reaction, bone is not formed. There is fibrous tissue that is formed. So TB arthritis ends up in fibrous ankylosis if not treated. Pyogenic arthritis or septic arthritis usually ends up in bony ankylosis if not intervened. But remember, there is an exception to this. TB causes fibrous ankylosis in every joint except the spine. In spine, TB causes bony ankylosis. So TB spondylitis, bony ankylosis. TB arthritis, fibrous ankylosis. Please remember, it's a tricky MCQ. A lot of times it is asked. Okay, please remember that. Now, in bony ankylosis, obviously, because the bone has grown into bone, there will be no movement. And since there is no movement, there will be no pain, and it will be a very stable joint, but there will be no movement, right? So no movement, no pain, stable joint. But will it be functional? No. Whereas fibrous ankylosis, some amount of movement will be there. And if some amount of movement will be there, some amount of pain will be there. And if some amount of pain will be there, it will be unstable. So some movement will cause instability and some pain. So that is the clinical differentiator between fibrous ankylosis and bony ankylosis. Now that is ankylosis, a disease process leading to fusion of the joint. What if we as surgeons want to fuse a joint? That is known as arthrodesis. Arthrodesis and ankylosis are technically the same thing. The joint is being fused. But arthrodesis, we want to fuse it. Ankylosis, the disease process fuses it. Okay, so arthrodesis is surgical fusion of joint. And why would you want to do it? In conditions where you want to fuse the joint because the treatment is not available or the deformity is there or there is a pathology. There are many indications of arthrodesis that you don't need to know right now. But if you recall at your level, just one, that is CTV. A neglected CTV presenting to you after 10 years of age. What are you doing? You're doing triple arthrodesis. You're fusing 3 joints. So in order to patient to have a stable foot to walk on. Right? You remember that? Triple arthrodesis from CTV. So what is arthrodesis? Fusion of the joint surgically. What is ankylosis? Fusion of the joint because of the disease process. There are 2 types, bony and fibrous, and you know what causes what. Now let's talk about a variant of septic arthritis. Essentially, it's the same thing, only that it occurs in infants below 1 year of age. And it affects the hip. We call it Tom Smith's arthritis. It's nothing but septic arthritis. But we have a different name for it, and I'll tell you why. Septic arthritis of hip in infancy in less than 1 year. This is known as Tom Smith's arthritis. So now why all the hallahu and why the different name? The different name is for a reason. It's this. You see, in children, the head of the femur is mostly cartilaginous. So suppose this is the growth plate. This is the head of the femur. We call it capital femoral epiphysis. Right? This is the epiphysis. This is the metaphysis. Call it the capital femoral epiphysis. So this is mostly cartilaginous, right? So this is cartilage. So what happens if there is septic arthritis of the hip? This pus and the proteolytic enzymes of the organism will destroy the head completely. And what will you be left with? You'll just be left with some amount of neck here and the acetabulum. And this will be the hip joint. So there will be no bone here. There will be no head. Total destruction of head because it is cartilaginous. And this total destruction of the head, which is cartilaginous, is known as chondroathenia. Lysis. Again, I told you, everything is written in the PPT. Just listen to me and understand what I'm trying to teach you. You can write down your beautiful notes later. Okay, so chondrolysis. Chondrolysis happens. And when this happens, what will happen? The gap will be there between the femur and the acetabulum. And this gap will lead to telescoping of the limb. What is telescoping of the limb? You can pull and push the limb. Normally, when the head of the femur is sitting inside the acetabulum, you cannot pull and push the limb. If there is no head of the femur, you can pull and push the limb. This is like a telescope. We call it telescopy positive. Look at this. Since the capital femoral epiphysis is cartilaginous, the disease process destroyed it, leading to chondrolysis. And there will be destruction of the hip, leading to telescopy positive. Hypermobility of the hip joint, because head is not there, so hip will be hypermobile, and limb will obviously be shortened. Look at this X-ray. Clearly here there is a normal head of the femur and the neck of the femur. Here there is only neck. Head is completely destroyed. Limb is shortened, hypermobile, and there is telescopy positive. This is a very important distinction, because normally we read in septic arthritis there is bony ankylosis, but here, because it is cartilaginous head, it's totally destroyed. Instead of ankylosis, there is hypermobility. Okay, and this is the stark difference between other types of septic arthritis, and that's why you have to remember it as Tom Smith's arthritis, which is an emergency, because if you don't intervene in time, the patient will lose the function of the hip. Now, in contrast to this, there is something known as transient synovitis. First of all, this is not septic arthritis. This is a transient synovitis. It's a self-limiting condition. Basically, the story here is that it's an antigen-antibody reaction because of a pre-existing viral infection in your body. You had a pre-existing viral infection, and because of this viral infection, there is antigen antibodies that has been formed, and these antigen antibodies go to your synovium and cause synovitis. And because of this synovitis, there is synovial fluid overproduction, causing stretching of the capsule and then causing pain. So patient presents to you like septic arthritis because of pain, but otherwise nothing is same. This is just transient. It is self-limiting and it will go away. In fact, it is the most common cause of a child with a limp. The most common cause of a limp in a child. Okay, this usually occurs in children. Between 6 to 12 years of age. And I'll show you the difference. Went down. So it's a self-limiting inflammation of the synovium. History of recent infection that is usually viral. It's an antigen-antibody reaction manifesting as synovitis. So far, so good. Okay, so far, so good. Usual age group is 6 to 12 years. Septic arthritis usually occurs in younger children, less than 5. So age is quite close to each other. That's why you always have to be careful, because a patient with septic arthritis may present to you early on with less fever and you might miss it, leading to destruction. Or patient may come to you with transient synovitis and you can act very aggressive and start antibiotics. So you can't be very aggressive. No, you have to be careful. So how do you distinguish between patient of septic arthritis and transient synovitis? Clinically, it is a challenge. But the best investigation would be to go inside the capsule and pull out the content and see what it is. If it's a pus, it's septic arthritis. If it's just synovial fluid, it's transient synovitis. But that's not always done, right? So best investigation, yes, go for aspiration. Otherwise, clinically, it's a challenge, because here also the patient has pain, patient has limb, and the patient is keeping the limb in a position of ease. Because there is stretch of the capsule, there is pain, and he wants to relieve himself of the pain, so he will keep the joint in position of ease. So how do you differentiate it? You have something known as Cocker's criteria. Cocker's criteria has 4 parameters. If the patient is unable to walk, if the fever is high, if the ESR is high, or if the WBC is high. Okay, each will get a point, and as the points increase, the chances of it being septic arthritis is more. So use Cocker's criteria to differentiate between transient synovitis and septic arthritis. And if it is pointing towards septic arthritis, go for arthrotomy. And if it's pointing towards transient synovitis, wait and watch. Observation. Just wait and watch. That's why transient synovitis is also known as observation hip. Just wait and watch. Now let's talk about the infections that occur on the hand. Now there are 3 types here. There is paronychium, there is Phelon or Whitlow, and then there is tenosynovitis. And I'll explain. And again, like I said, everything is written in the slides. Just pay attention to the story and then you can write down your notes. So what is this paronychia? Paronychia means around the nail or running around the nail. Right? It is the most common infection of the hand. The story here is, you must have seen this, when you try to remove this dead skin here around the nail and you pull it out with your teeth. There sometimes is an infection that runs around your a nail. That infection, that running around the nail infection is known as paronychia. You can clearly see that there is swelling and there is collection of pus here around the nail. This is known as paronychia. Running around the nail, it is the most common infection of the hand. Obviously, tell me what is the organism that is causing paronychia? The most common organism is Staphylococcus aureus. That's it. So infection running around the nail sometimes goes into the nail bed. How will you treat this? Antibiotics should be fine, incision and drainage if required. And sometimes what happens, the infection, if it reaches the nail bed, you have to remove a part of the nail. Okay, antibiotics, drainage of the abscess, and removal of the part of the nail. That is paronychia. Then there is Phelon or Whitlow. What is Phelon or Whitlow? Phelon or Whitlow is basically infection of the pulp. Infection of the pulp or the subcutaneous tissue. Right. The most commonly affected finger is thumb because you put your thumb everywhere. Right. What is the most common organism? Staphylococcus aureus. So Staphylococcus aureus, thumb, and it's the infection of the subcutaneous tissue of the pulp of the finger. Right. Mostly distal. Now, what are the complications? Why is it a problem? The complication is that because of this infection in the pulp, the infection can reach the bone, leading to osteomyelitis of the phalanx, right? Osteomyelitis of the phalanx is a very, very important complication of Phelon or Whitlow. Sometimes it can reach the tendon, leading to tenosynovitis. So in order to prevent this, you need to treat it early. What is the treatment? Obviously, antibiotic, and because there is an abscess, you have to drain it. Now the question arises, how will you go for a drainage? You have to go for a vertical incision. So that you can break all the adhesions at the pulp of the finger so that there is no residual infection hiding anywhere. So vertical incision and break all the septae and adhesions so that the pus and the organism comes out. So antibiotics, incision and drainage with vertical incision to break the adhesions and the septae that hide the infection. That is the treatment of Phelon or Whitlow. And if not treated on time, you can go into osteomyelitis or tenosynovitis. Talking about tenosynovitis, what is tenosynovitis? It's the infection of the tendon sheath or the tendon itself. Obviously, what is the most common organism? Tell me. Staphylococcus aureus. It's fun now. Now, what is tenosynovitis? Inflammation or infection of tendon sheath. What is the clinical presentation? Apart from the systemic presentation of fever and all that, local presentation. What are the local findings? There will be swelling. There will be fusiform swelling of the finger, and there will be an attitude of flexion. So there is flexed finger with swelling. Whenever you extend the finger passively, there will be pain. Or whenever you tap on the tendon that is inflamed, there will be pain. Okay, when you tap on the finger, there will be pain. So pain on tapping of the tendon, flexion of the finger, fusiform, uniform swelling of the finger, and pain on extension. Right? These are the characteristic findings of tenosynovitis. And Canavel sign is the term that is used to describe pain on tapping of the tendon. You should remember this. This is a sign that is seen in tenosynovitis. Can you tell me the treatment now? I'm sure you know the treatment now. Antibiotics, incision and drainage. Right? Antibiotics, incision and drainage is the treatment of tenosynovitis.